We're going to have a further session on deconstruction of technique with both endoscopy and colonoscopy. We're going to start with a presentation about endoscopy, run to a couple of pre-recorded video sessions, and then get back to a presentation and discussion about treatment of polyps.
If there's some tip angulation, if we rotate the instrument along the longitudinal axis of the shaft, it will rotate and move. Okay? So the easiest way to do this, in fact, if the scope is inside the patient and you're in the neutral position, is simply to bring your left hand up. And it rotates the scope 90 degrees. And then a little bit more, and eventually you hit your chest. If you wanted to rotate the scope a little bit further, instead of hitting your chest, you can rotate your body. So we can bring our hand up to our chest, we can rotate our body. If necessary, we can add further angulation by rotating the wrist. You'll note what I don't do is grip the instrument and apply torque with my hand. And the reason for this is, firstly, the scope is relatively short, and the coils here are trying to keep the scope straight. If I'm applying torque at the tip using my hand, there's a similar loop being put in between my hand and the head of the instrument, which has remained static in my left hand. So as I apply torque, this becomes increasingly more difficult to do, and I can't actually do it with my fingers. I have to use a fist. Well, obviously the angulation at your wrist limits how much torque you can put in. And in gastroscopy, you're going to need a lot of torque. In addition, you don't want the shaft of the instrument to be fixed. You want it to be able to move freely, and this hand is only going to support the instrument. So you never grip the shaft of the instrument in gastroscopy to apply torque. We do that using the maneuver by rotating along the longitudinal shaft using your arm or your wrist.
Hi, and welcome. I'd like to talk to you about my 5 top tips for colonoscopy technique. And this is kind of a little bit about what I wish my trainer maybe had told me back when I was being trained. I have no disclosures. So you can think of colonoscopy as a little bit like a black box. You have some inputs, you have what happens in the middle, and you have some outputs. So if we just look at this, do you remember this? Back when you were learning to drive maybe, and yeah, you got in the car and you put your foot and there were these pedals and you try to go and oh my God, I have no idea what I'm doing. Maybe you were sitting next to one of your parents like I was, and you just realize how little, at that very moment, how little you know about how to drive a car. Well, that's a little bit unconscious. Well, before you get in the car, you're unconsciously incompetent, right? You don't know that you can't drive the car. But as soon as you sit in that car, you're consciously incompetent. And then you can either go one of 2 ways. You can either become consciously competent, where you understand what you're doing, and that's you take driving lessons, right? And you understand that when you press the clutch, that's when you can change gear, whereas when you got the clutch up, you can't change gear. Or you become unconsciously competent, which is when all of us is just driving around all the time. We're not really thinking about driving. Maybe we're thinking about what we're going to eat for dinner, or what we're going to buy for our wife for a wedding anniversary or something. So that's the unconscious competence. Now, we in colonoscopy training don't really want to be going towards unconscious competence. We want to be going to conscious competence. Well, what does that mean? Well, if we just look at an example, when you're talking about colonoscopy, which is what we're focused on here, you can have multiple unstructured inputs going into the black box. But what you're going to get out is slow solutions. Maybe you don't get a solution. The byproduct might be that the patient has significant discomfort. The procedure takes longer. Maybe you get there in the end, but maybe you got there via lots of discomfort, lots of trial and error, and potentially, if you're in a fee-for-service environment, a loss of revenue. So that's the unconscious competence or the conscious incompetence approach. But if you have a situation where the inputs that you make, the changes that you make during your colonoscopy are maybe proactive, they're structured, they're applied logically and sequentially, you will get a situation where the outputs are rapid, dependable, the patient potentially in this situation gets less discomfort, and there is a shorter procedure time. So conscious competence, able to train others. So I want to talk in the next 15 minutes about 5 common scenarios. This is 5 top tips, so we've got 5 scenarios. 90% of the time in these 5 scenarios, the same pattern occurs. If you know the pattern, you can recognize it early, and you know what things are in 90% of the cases going to make a difference to the outcome. Therefore, your inputs can be structured, applied in turn and quickly, and in a logical fashion. And this will lead to quicker intubation, painless intubation, and more time for the most important thing in colonoscopy, which is adenoma detection. I'm sure that you know from the GIEQs site, if you're looking on GIEQs Online already, you'll be looking and you'll be seeing lots of our videos with a magnetic imager. Just to say that there are 2 views, the anterior-posterior view, that's front to back, and the supine view from above the patient. And the classical view starts with the sigmoid, descending, splenic flexure, transverse hepatic flexure, and the cecum. Now, some common advice, you should always maintain a luminal view. Patient has discomfort, you need to change something, you need to do something differently. Pushing through when the patient has discomfort leads to problems usually, particularly maybe the patient being angry with you, but more than that can lead to complications, adverse events. If you fail the same maneuver twice, you try something twice, don't keep trying it, change something, and be proactive, not reactive. So my first tip, patients got discomfort in the left colon during intubation. What do? This is the unconscious competent approach. So you minimize this to minimize, your intention is to minimize discomfort in the left colon. What do? You give more analgesics. Okay, that works, but here's maybe a better way. So the endoscopist has already asked to move the patient. Endoscopist is in the sigmoid. How do you know that? Because on the scope guide, you can see that it's just about to make the junction between the sigmoid and the descending colon. Patient's again been rolled. So from left lateral, we're now on supine, we're now on right lateral. And you can see that the endoscopist is applying a significant amount of torque with his right hand, so much that there becomes a loop. So what loop would have entered the patient is now external. And just then, you saw the endoscopist take that loop out and flip the scope back round. So this already, and again, another external loop going in, so that's already 180 degrees of clockwise torque applied to the scope and 180 degrees applied to the patient because the patient has moved. So you can get torque by moving the patient. You can also get torque by adding turn to the endoscope. So the consciously competent approach to discomfort in the left colon might be to, yes, you could give extra analgesia and anxiolytics, but maybe better slow down. Think about what you're doing. Add clockwise torque either by moving the patient to the supine, then right lateral, or adding clockwise torque, and using water instead of air for insufflation, because this minimizes the degree of stretch, and therefore there's less distance for the scope to travel with less discomfort. Now, I think I've put on the right why it works. You can read that at your leisure. But this is a summary of the consciously competent approach to discomfort in left colon intubation. And this would be one of my tips. My 4th tip, visualizing the cecum. Now, there's another talk in this symposium all about maintaining cecal visualization and how you can quantify maybe, hopefully in the future, how much of the cecum you've seen. So to maximize cecal visualization, potentially you can spend ages, and you see this picture here, suctioning the fluid here, distending it with air or CO2. And why does that work? Well, of course, that works, but it takes some time. More about this. The endoscopist has clearly got fluid and problems in the cecum, but they turn the patient to the supine and then to the right. And look, now the cecum is totally empty of fluid. So my 5 top tips then for what I wish my trainer had told me. I'm just, Roland Valora and John Anderson were my trainers and are both at this Congress, so I have to be pretty careful here. But I might say that my 5 top tips that they probably, if I'm really honest with myself.
So I'm just going to ask our trainees, just quickly, Hannes, a top tip you got there for that you're going to do differently, anything?
For me, the best tip is actually the patient positioning. That was something really new, because in the past I always had patients under fully sedation, fully anesthesia. So we actually never changed patient position, and that's really something new and for me the most helpful.